All right, good morning. Give a couple of minutes for everyone to get out of the waiting room and into the population with all of us. Got about 200 more participants coming in, so I'm gonna give a couple more minutes. All right, I think everybody's here. Good morning, everybody. Welcome. This is our webinar. It's gonna be starting momentarily. Just letting you know that your microphones will be muted while presenters are speaking. Please turn up your audio. Use the Q&A feature for questions and answering because the chat is going to be disabled. Also letting you know that this session will be recorded and captioned. Captions, recordings, and transcripts will be posted to the DHCS website within 7 to 10 days for your viewing pleasure. Next slide. And like I said earlier, good morning and welcome to the third installation of our Learning Collaborative here with the California Advancing and Innovating Medi-Cal. Today, we're going to be going over the behavioral health services, claiming and billing. Welcome back if you visited the last two learning collaboratives. If you haven't, then welcome to your first one. We appreciate you coming, and hopefully we'll all learn something today. Next slide, please. We're going to do some welcoming and introductions. My name is Greg Tate. I'm a section chief here. The next slide, I'll be showing there we go, meeting our Justice Involved Initiative, Reentry Initiative team. At the very top, we have our Deputy Director, Autumn Boylan. She's on the call here and she'll be presenting later. As I mentioned earlier, my name is Greg Tate. I'm one of the section chiefs over the California Reentry section, or correctional facility oversight section. Sorry about that. And on my other side of the house in the branch is Lawana Welch. She'll be presenting also earlier. She's over the Reentry Services Oversight section. Underneath us, we have three unit chiefs, Michael Gillis, who will be presenting right after me. He just waved. Mike Hadeen, who's also on the call, and Miss Megan Shandell, who is actually out of office today. Next slide, please.
Greg, can I jump in real quick here? And sorry to throw off your flow, but
No,
I
it's all
did
good.
just want to quickly, good morning, everybody. Did quickly want to make an announcement here. You may have noticed that our org chart looks a little bit different than it did in the prior sessions. Sydney Armendariz recently left DHCS for a new opportunity at the California Department of Public Health. She's moving on up in the world, which is very well deserved, and will be a loss to our team, but we're committed to working with you all. I know that you all, have developed relationships with Sydney over the last couple of years, and want to make sure to reassure you that we are committed and staffed up and ready to go. We are going to be recruiting for Sydney's position, and we'll introduce you to our new branch chief, but please do let your colleagues know that we have an opening at DHCS, and you're in very capable hands with Greg, Luana, Michael, Mike, and Megan. So, and me, of course. Just wanted to make sure folks are tracking, and thank you very much. So Greg, back to you.
No worries. Thank you so much, Autumn. Let's see. Oh, next slide, please. So today we have our colleagues at the Medi-Cal Behavioral Health Division, McBid. That team oversees the policy and program areas and specialty mental health services, drug Medi-Cal or DMCs, and drug Medi-Cal organized delivery systems programs. So they'll be on the call to help out with our Q&A later on today. Next slide, please. All right, so right now we're going to ask you guys, like we have for all the learning collaboratives, is we want to put a poll up to see what role you play in this initiative. We want to see where you're coming from, who's all, people are already adding to it, but if you're with the county jails, or with your county youth correctional facility, the sheriff, CDCR, any behavioral health agencies, social services, managed care, reentry, EMC, or just other, I just want you to click and answer in the poll that just got posted to see who's on the call with us today. I really appreciate that. I see county behavioral health agencies are on, which is good because that's what this collaborative is going to be about. It's good to also see that we have some county jails and youth correctional facilities here as well. Give it a couple more seconds to see if more participants want to answer the poll that was just posted. All right, going once, going twice. I think that's good for now. All right. Let me see. You want to wait a couple more minutes for that poll? Give them some time to answer. All right, we appreciate you guys answering the poll. Next slide has our collective working norms. All right, so our collective working norms. Basically, we want to be curious. This is space for learning and problem solving, so we're going to be working together with that. We want to remain mission driven, focus on person-centered approaches to successful implementation of the Reentry initiative. Be present and interactive, sharing success and failures to help others learn, because we're all in this together, we're all learning together, and we're building the plane as we're flying, as we keep saying. Think beyond your sector, continuing to build strong partnerships between stakeholders involved in correction and healthcare delivery systems. We're going to create a safe, judgment-free working space, where we can take risk and share our obstacles and find solutions together. A lot of the collaboration, which is why we're doing these. Continuously provide candid and constructive feedback. What challenges are you having, or what kind of difficulties, road bumps, speed bumps, as you want to call them. And we also want to seek opportunities to collaborate with one another, with other participants beyond formal settings hosted by the state. So you guys can reach out to each other, or county entities can talk to one another, even without the state being the overview of it. And also the last one will be solution oriented, maintaining a bias towards action as the Reentry initiative is launched. So we have 4 days before go live. So should be very interesting to see how things are moving forward. And we're excited, and we really appreciate everyone being on the call today. With that, I'm going to pass it on to my section chief here, Michael Gillis, and he will talk about the past 2 recaps of the learning collaboratives. Thank you so much, and look forward to talking to you guys later.
Thank you, Greg, and hello and good morning to everyone. So just going over a recap of session 2, the JI screening portal. On Thursday, September 5th, DHCS hosted the second learning collaborative session, followed by a 1 hour office hour session on September 12th. The learning collaborative session 2 recording is available in the link provided, which will be circulated in the slides at a later time. During this conversation, we covered key topics, specifically helping our implementation partners understand the purpose of the JI screening portal, providing guidance about the required JI aid code and how to ensure facilities are tracking the 90 days of pre-release services, improving understanding of the use of the pause, reset, and restart associated with the 90-day benefit period, identifying best practices, requirements, and providing services to individuals with short-term stays in the county correctional facilities. So really important and impactful on our short-term model. Introduction into county partners that will be ready to launch with the initiative in October. So previously, 2 of our 3 counties actually providing their lived experiences. So that was really wonderful. And if you didn't have a chance, I would recommend going and listening to the recording. Next slide, please. The key takeaways and best practices from our county panel, so specifically that panel that I referenced earlier as our last point, were that we starting a pilot now, so you are ready to go live at your go live date. So the sooner you start, the better off you'll be. If you have an on-site pharmacy, explore a 24-hour model to ensure medications can be provided upon release. Be realistic about what you can and what can be accomplished in those first 24 hours of release. And reception of an incarcerated individual. Implement a test day prior to go live to confirm processes and procedures for medications in hand upon release. Explore releasing all individuals with meds in hands, regardless of eligibility, and recoup the payment later. Partner with the Department of Human Assistance to support Medicaid enrollment and eligibility process. Ensure that custody is also trained on the new short-term model and protocols. Utilize telehealth for each provider appointments and leverage bulk reporting in the screening portal. Next slide, please. Today's agenda, we will be covering supporting the implementation partner's knowledge of covered behavioral health services, improving understanding of the behavioral health clinical consultation requirements, outlining the timeline and further requirements for BH links, and then also identifying requirements and best practices for administering medication assisted treatment, and then finally learning from subject matter experts on our MANAT or medication assisted treatment implementation. And with that, next slide, please. And then this is our overall learning collaborative timeline. So today we are on September 26th, our behavioral health screening services learning collaborative. Next will be our non-behavioral health screening services on October 17th. November 14th, we will cover enhanced care or management for JI populations of focus. And our final will be December 5th, which will be pharmacy e-policies. And as I mentioned earlier, each one of our learning collaboratives is followed by a preceding office hour the following week. And we encourage you to come after this session to the office hour on October 3rd for further conversations and questions that you may have related to today's session. And we thank you so much for your time. And with that, I will turn it over to, I believe, Autumn Boylan for our next set on the overview on covered or behavioral health services. Thank you so much.
Thanks, Michael. I think that's actually Luana. So I'm going to kick it over to Luana. Thanks.
Thanks, Autumn. Now let's do a quick overview of covered behavioral services. A core objective of the initiative is to diagnose, treat, and stabilize individuals with behavioral health conditions and form connections to community-based treatments. Just to give you some historical data, the percentage of individuals with mental health needs in California jails has risen 20% risen from 20% in 2010 to 53% in 2023. 51% of people in prison and 71% of people in jail in the US have or previous had a mental disorder. 58% of people in state prison and 63% of people in jail in the US meet the criteria for drug dependence or drug abuse. Overdose deaths are more than 100 times more likely for justice-involved individuals 2 weeks post-release than anyone in the general population. For these reasons, we have required the following services in our main behavioral health focus areas, which we will go in detail further in the presentation. So we have behavioral health clinical consultation services, medication assistant treatment services, and behavioral health links. Next slide. We require correctional facilities to screen all individuals for mental health and substance use disorder needs. This will ensure individuals with behavioral health needs are identified and the proper behavioral health links are provided to qualifying individuals. Some of the components of the needs assessments can be prior mental health or SUD treatment and diagnoses, screening results from a validated screening tool, which we'll show in the next slide, a need for mental health or SUD related clinical consultations, identification of any needed mental health or SUD medications while incarcerated or upon release, identification of any potential benefit for long-acting injectable use for mental health or SUD, the identification of the need for any behavioral health link for county-based behavioral health services, the identification of the need for mental health or SUD follow-up and appropriate level of care. Just a reminder, our goal is to leverage existing processes to the maximum extent possible. For example, CDCR can leverage their existing screening and placement processes to determine the need for a behavioral health link. Counties can also leverage existing processes for screening and placement to the extent those processes meet these program screening requirements. Next slide, please. Pre-release care managers are to screen for mental health and substance use disorders to determine appropriate links and referrals to use. Also, pre-release care managers must use a validated screening tool. Correctional facilities and county agencies must agree upon a health risk assessment screening tool to determine if an individual's behavioral health need met the criteria for a county referral. Evidence of this agreement is part of correctional facility readiness assessments. Here are on the screen are some recommended but not required options for screening tools that are validated and reliable in the justice settings. And some of these are probably familiar to most of you. As a reminder, this list is non-exhaustive and correctional facilities can use whatever clinically validated tools they have or they're currently using. Let's see, next slide. Okay, well, now I'll send it over to Autumn Boylan to go over the behavioral health services in detail.
Thanks, Luana. Good afternoon or good morning, everybody. Wanted to kind of dig in a little bit more about what these services actually mean for correctional facility county partners who are implementing the waiver. We know that, calling something clinical consultation doesn't really describe what that entails or what that means from a billing perspective. And so we wanted to do a little bit deeper dive in today's session to help people better understand exactly what kinds of services you can get reimbursement for under this model. So for the clinical consultation pieces specifically, this includes services that are necessary to diagnose, treat, and stabilize individuals, which means it's the actual provision of services, including behavioral health assessments, anything that would be considered outpatient clinical services, such as psychotherapy treatment, for example. It could also include individual or group treatment in the case where you are hosting groups of services for individuals with particular conditions or needs, and so that could also be included. And it would include prescribing medications, psychiatric medications, for example, and then the administration of those medications as well. It also includes clinical documentation for all medications and services that'll be needed in the immediate post-release period. So kind of part of that transition planning and documenting as part of the reentry plan, the services and supports that the individual will need, including their treatment plan and all of those pieces, once they're discharged from the correctional facility setting. So the terminology that we used from a waiver perspective about clinical consultation really wraps up and rolls into that umbrella, a pretty large array of services and supports that can be delivered to individuals in the carceral setting while they're still in custody during that 90-day period. And so wanted to make sure that folks are kind of tracking that larger picture. Next page. Already talked through some of these things, but as you see, there's, these are just examples of the types of services. It's not exhaustive, but also includes SUD care coordination, for example, peer support services, which are a part of our especially mental health services and drug medical organized delivery system infrastructure to allow that peer-to-peer support and consultation from individuals with lived experience of having a mental illness or being a family member of someone with mental illness or substance use disorder, which is a critical component in terms of the success for engagement of services and all of those pieces. So we want to make sure that you're understanding kind of what's included there as well. Next. going a little bit deeper into the peer support services model and making sure that you are thinking about how peers can fit within your delivery system and the role that they could play in terms of the overall delivery of care. Peer support services are an improved part of the pre-release services package and will be billed while the individual is in the pre-release setting through our fee-for-service delivery system. And then once the individual is released back into the community, those peer support specialist services can continue through our county behavioral health agencies. They provide critical care management supports and kind of that are key to that trust building process. Again, it's really about making sure that folks stay engaged in care when they're working with somebody who has a similar life experience, has been through their own issues related to mental health services and been working through recovery, that they're more likely to actively engage and to make those connections that are critical for the patient engagement to happen. And so, it can be provided through the InReach model to make sure that county peer support specialists who are working with the county behavioral health agencies today are able to help make those connections during that pre-release period and be a part of that overall delivery system infrastructure. It really, allows the team model to focus on that strength-based coaching, supports linkages to community resources, and make sure that our Medi-Cal members and their families are aware of the services that are available to them, that they have information about their conditions, and that they can start their own journey towards recovery from both mental illness and substance use disorders. Next. So we want to talk a little bit more about that behavioral health link. So we just heard about kind of some of the services that can happen in that pre-release period, either through an embedded model or, with peer support specialists with the InReach model. But, what is the role of the county behavioral health agency in really making those connections and supporting individuals when they release back into the community? That's really the infrastructure and support system that's available in each county to make sure that individuals have the appropriate level of care in the community as well. It also is available through our Medi-Cal managed care plans who may treat individuals with more mild to moderate conditions through their network of behavioral health providers. And so really thinking about that linkage to the appropriate payer and caregiver provider, I should say, in the community is really critical to the long-term success for our individuals to stay engaged with care. So the links are really a very critical component of the overall waiver implementation in terms of how correctional facilities and county behavioral health agencies and managed care plans are coordinating care to implement that linked behavioral health service delivery infrastructure. It's really about making sure that there are facilitated referrals and that the partners such as the county behavioral health agencies and managed care plans are brought into that care planning and reentry planning process, including for the professional clinical handoffs. In some cases, for the professional clinical consultation handoffs, a person's acuity level or the complexity of their circumstances make it such that it's important for the embedded clinical consultation providers, so your LCSWs or your licensed marriage and family therapists or your psychologists or psychiatrists, that they are working with the individuals who will be providing care, including following through on the treatment plan in the community, that there's a connection and that those professionals are able to share not only data, but make sure that kind of the treatment plan is available, that there's an opportunity to discuss more complex cases. In some cases, it's really about data exchange and sharing of notes. In some cases, it's about having a conversation, but making sure there's that coordinated handoff from a professional perspective. Next. We talked a little bit about this already in terms of the purpose for behavioral health links, but it's really about that continuity of care to make sure that the individual who, his treatment plan is being developed during the carceral period is able to continue on that same journey and that same path. And so it's important to have this coordinated reentry planning and to make those linkages and to keep people engaged in care once they leave the carceral setting so that they can continue to get the treatment that they need while they're in the community as well. So part of the purpose of the linkage is to create that intensive kind of care management model for people with mental illness and substance use disorders. And I've talked through, I think, all of these components already, but you see them all laid out here. And I think it really makes a very clear picture about, what is our intent of what we're trying to do with these behavioral health links, and why is it, so important to the success of the waiver, but also, on the prior page, there was a link out to the statutory obligations, but this is also a statutory mandate in California to create these linkages. And we felt that is so important for all of the reasons that Greg and Luana shared in their overviews of the program, that we get folks with mental illness and substance use disorder services connected to the appropriate levels of care. Next. So what are the appropriate levels of care? And I think that making sure that you understand the current landscape for the behavioral health services delivery within the Medi-Cal program at large is really important. So it's our county behavioral health agencies who provide all of our Medi-Cal substance use disorder services. And they do that through 2 different delivery systems, and that varies by county. So one county doesn't implement both of those systems, but across counties, they are either participating in our drug Medi-Cal program, which offers state plan services for substance use disorders to our enrolled Medi-Cal members, or they are part of our 1115 waiver demonstration known as the drug Medi-Cal organized delivery system. But really, at the end of the day, it's the same function that the county plays. It's maybe a different array of services. The DMC ODS is really anchored to the ASAM model, whereas drug Medi-Cal is less anchored to the ASAM model, but I think many counties still employ the ASAM criteria, but it's really about making sure that people are connected to substance use disorder services in the community-based setting and provided for all arrays of substance use disorder types of treatment, including the provision of medication-assisted therapies or treatments or MAT services in the community as well through narcotic treatment programs and others. The mental health delivery system is shared responsibility between our county behavioral health agencies who are responsible for especially mental health services delivery system, which really focuses on, for adults, individuals with more severe and persistent mental illness, kind of the higher acuity needs for adults, and for younger people, really kind of that no wrong door approach. You may have children with diagnosed mental health conditions who need more intensive treatments and supports through our especially mental health services delivery system, or a history of trauma, as most of the individuals, if not all of the individuals who are leaving incarceration who are under the age of 21, or foster youth under the age of 26, an experience of trauma or adverse childhood experiences would qualify those young people for specialty mental health services. The non-specialty mental health services benefit is really for individuals with more mild to moderate conditions that can be treated in a less intensive manner. So somebody, for example, who may have an anxiety disorder, but they're managing through medication treatment and checking in with a psychiatrist or checking in with a therapist for less frequent psychotherapy, for example, but rather than more intensive outpatient supports or the residential or psychiatric inpatient treatment that would be provided through our specialty mental health service delivery system. There is a transition tool or level of care tool that we developed for community settings, but it doesn't translate as well for the justice carceral setting. And so what we're trying to really do here is encourage correctional facilities to work closely with your managed care plans and county behavioral health agencies to really determine what is the appropriate level of care in terms of the managed care, non-specialty mental health delivery system, or the specialty mental health services delivery system delivered through our county behavioral health agencies. We do have a no wrong door approach though, and so in any case if a referral is made, the health plan or the the county behavioral health agency will help to make sure that individuals are getting connected to the appropriate level of care. We just want to cut down on the number of steps so that linkage and those conversations about levels of care are really important in that pre-release period. Next. Wanted to just make sure folks are tracking in terms of our timeline for our correctional facilities and county behavioral health agencies for completing the behavioral health links, both in the short-term model and kind of, thinking about what that looks like in a county correctional facility setting. So, within 10 days of incarceration, making sure that screening and assessment for qualifying behavioral health conditions is happening even sooner for the provision of MAT treatment or other medications that need to be administered to the individual, but making sure a more complete health risk assessment and behavioral health screening assessment is done at that 10-day mark to ensure that individuals who may not have previously had a diagnosed mental health condition or substance use disorder condition can be identified and appropriately treated. I want to make sure that during the incarceration that the correctional facility is obtaining consent for the behavioral health link and sharing of data, including information from the medical record, and reviewing health records to determine if professional clinical consultation is appropriate. These activities can all be billed as part of the care management bundles through our fee-for-service billing system. You'd also, during this period, schedule and facilitate that professional clinical to clinical consultation based on kind of the needs of the individual and do post-release follow-up. And I think that part is really important to emphasize because I want to make sure that once an individual's released, there still is a role for folks to be coordinating to make sure that that post-release follow-up is happening, that the appointments are scheduled, transportation is being arranged for, and that the reentry care plan is being carried out appropriately. And that folks know that an individual has been released back into the community. That's the most important. Next. We're going to talk also about medication-assisted treatment requirements. So if you go on to the next page, we're going to talk a bit more about MAT provision later in today's session, and there's going to be a whole panel and discussion about medication-assisted treatment. But from a waiver perspective, including what we put in our policy and operations guide, the goals of providing MAT in the reentry initiative are to ensure that individuals are getting all of the medications that they need for the treatment of a substance use disorder, that people who need methadone are getting access to methadone or other SUD medications, that people who are pregnant or postpartum are getting access to the medications that they need for substance use disorders to ensure that they can have a healthy pregnancy, that their child can thrive if they carry through the term of the pregnancy. We want to make sure that that there's concurrent care for behavioral health happening in correctional facility settings, that people are getting access in a timely manner, that they're getting access to the services that they need to stabilize their substance use disorders, which is, really what MAT is all about. And it's also making sure that opioid overdose reversal medication is available, Narcan, for example, and that staff have been trained in its use and that it's made available to individuals as they're leaving the correctional facility setting. We've heard from many of you that is happening now, but that people are leaving the correctional facility with their medications in hand upon release, that as clinically appropriate. Next. So what are the specific requirements? It's really about timely provision of services to make sure that people are getting the treatment based on their preference for agonist, or antagonist treatment, depending on what were they doing before they were incarcerated. If they weren't receiving treatment beforehand, making sure that they are consenting to the appropriate type of treatment. Managing opioid withdrawal through either methadone or buprenorphine, for example, using evidence-based tools and interventions. And then continuation of medications that had been previously prescribed in the community. And that's the part that I think is really important, is like making sure that folks are understanding and timely providing medication supports to continue a course of treatment that has already been initiated in the community before an individual is incarcerated. That there's appropriate tapering or discontinuation of medications as clinically appropriate, and again, that the medications are available to the individual as they're leaving the facility, so that there isn't a gap in coverage. They're getting access and are able to continue on their treatment plan. Next. I think, just going into the treatment planning requirements component, making sure that as part of that treatment plan for all individuals have screened positive for substance use disorders, including opioid use disorders and alcohol use disorders, that those needs are identified as part of the assessment, that we're supporting evidence-based treatment of individuals, and making sure that the treatment is accessible to our pregnant and postpartum populations. As I said, we want to make sure that there's appropriate placement into a non-residential level of care for individuals who are estimated to be in the correctional facility for more than 30 days, that they're receiving evidence-based interventions such as motivational interviewing, peer support services, cognitive behavioral therapy, for example, and that they're maintaining continuity of care by having that clinical to clinical consultation and warm handoff to the community-based provider. Next. We're going to go into quite a lot about the provision of methadone in correctional facilities as part of our MAP panel today, but want to make sure that folks are tracking that we are developing a behavioral health information notice that will provide further guidance on providing MAT to incarcerated patients, and some of the options that correctional facilities will be able to implement for the provision of methadone services. You can administer or dispense methadone directly, but not prescribe methadone as an incidental injection to a medical an adjunct to medical or surgical conditions. You can provide methadone under a DEA 72-hour emergency rule, or permitted to request exceptions to regulatory provisions under the Controlled Substances Act, and the BHIN will go into more detail of these particular options. Next. All right, so what does this actually look like? We put together an illustrative patient journey of what this could look like. This particular model is for a longer stay based on kind of what we've learned from CDCR, but could, and also translate to county jails for individuals who have been incarcerated for a longer period of time, for example. But we know that it'll be different for the correctional facility, depending on the length of stay and incarceration, depending on several factors. This is just one example of many ways that this could play out, but it's really to help you understand how some of these needs would get met before an individual, but also what that would look like from a billing perspective, about which activities are actual service interactions that could be billed through this initiative. So this is a fictitious character named Matthew Carter with diagnosed bipolar disorder and receiving lithium for treatment. Has a substance use disorder and is also on buprenorphine and receiving counseling and peer support services. The Medi-Cal status is suspended because the individual is incarcerated for a longer period of time, but is activated for the 90 days prior to Matthew's release back into the community. In this example, we decided to use a known release date, but we'll happy to give other examples with unknown release dates. We know that that continues to be top of mind for for all of you who are running county jails in particular about, what that looks like if there's an unknown release date. But again, this is really just meant to illustrate what it would look like. And in this case, in this example, the correctional facility is utilizing a mixed model approach. Next. So in the CDCR state prison framework, the actual reentry period starts much prior to that 90 days of pre-release. Some of these things could translate to the correctional facilities as well, or might be truncated down to the 90-day period in beginning the reentry process for county jails. But for this example, we're going to follow the timeline that we've heard from CDCR. And again, this might not be right or perfect exactly. It's just meant to illustrate for the purposes of training in today's session. But our state prison partners begin that reentry process very early and make sure that the individual's pre-release medical application has been completed and submitted, and then sends confirmation to DHCS of Matthew's enrollment DHCS sends confirmation that the enrollment has been processed, or it's actually, I think that would be the county. But at any rate, it would be the eligibility check would be completed, and Matthew would be enrolled in the Medi-Cal program. The correctional facility staff verifies Matthew's Medi-Cal enrollment and confirms that he is already enrolled and suspended. So no need to take further action in terms of the Medi-Cal application. And the correctional facility staff does that kind of initial screening to determine if Matthew, an adult, is eligible for pre-release services, by meeting the healthcare services criteria. And then simultaneously, once the aid code is activated on 90 days, at the 90-day mark, the auto assignment process to enroll Matthew into a managed care plan in his county of residence will also be initiated. Next. Here you see like all of the stars and the legend you see at the bottom are where these are different billable interactions. And so it's meant again to illustrate the types of services that Matthew could receive in that 90 days prior to release back into the community. So continue receiving MAT and medications as appropriate based on the specific treatment plan that Matthew has from their care team, including their embedded care manager. And the correctional facility can begin to bill those services at the start of the 90-day pre-release period. Those services would be billed for the MAT services specifically would be billed through our Medi-Cal RX for the medication specifically. The services part, like administration and all of those pieces, would be billed to our fee-for-service delivery system, but the actual medications would get billed to our Medi-Cal RX fee-for-service delivery system. The care manager leverages Matthew's health history to inform a health risk assessment and identify several pre-release needs or objectives that could be billed through care management bundle number 1. Matthew receives clinical consultation services to determine additional medical needs, and that's a fee for service, or you see the red star there. The correctional facility administers the MAT treatment, so that's where I was saying the medications get billed to Medi-Cal RX. The administration service gets billed to our CAMUS fee-for-service delivery system. And as part of that process, the correctional facility clinician orders labs to be able to monitor the lithium intake, and the labs are submitted, and then that's also a billable service for the laboratory services. Matthew is seeing a psychiatrist for his conditions and a counselor to provide therapy services related to his bipolar disorder and substance use disorders to provide stabilization prior to release. And those are all billed, as you see in the red stars, through our CAMUS fee-for-service delivery system. Next. Within 2 days of the health risk assessment, the embedded care manager contacts the County Behavioral Health Agency to confirm that the assessment was completed and to begin the process for behavioral health links between the correctional facility and the county agency. The embedded care manager also contacts the community health worker through the ECM provider to help navigate care, community-based care, through care management bundle number 2. And 60 days prior to release. And again, these are all just illustrative timelines. There may be many other service activities that happen in this timeline that are billable. We just wanted to show you what it could look like, and this is just an example. But in that 60 days prior to release, the correctional facility staff use the portal to find Matthew's assigned MCP, managed care plan, and then contacts the managed care plan JI liaison to get that in-reach care management assignment so that somebody can start to work with the individual in the in-reach model, to build the care plan, to work with the embedded care manager and the Medi-Cal member to really think through kind of what is that reentry process going to look like. The embedded care manager arranges a warm handoff with the in-reach care manager. They meet, they talk, they get to know each other, and they start to talk through the reentry care plan. And the in-reach care manager then identifies housing resources that will need to be identified, and completes a housing application while Matthew is still in custody. They might also identify a primary care provider and behavioral health providers in the community, and making sure that information gets coordinated and post-release appointments are established. Next. 4 weeks prior to release, the embedded care manager schedules the professional clinical consultation and handoff between the correctional facility behavioral health counselor and the community-based behavioral health counselor through the county behavioral health agency network. And that gets billed through care management bundle number 2. And then 2 weeks prior to release, there's an additional connection made to a peer support specialist to help facilitate release. And again, these services can be billed to fee for service for the embedded care manager. And then the county receiving the link, and it's only for the county provider that's receiving the link, those services can be billed through our short Doyle system. The InReach peer support specialist has a telehealth visit with Michael to introduce themselves and make sure that they can start making those connections. And then upon release, the InReach care manager goes over the complete treatment plan with Matthew, provides a copy to the managed care plan and the county, and make sure that Matthew gets the medications that are needed upon release. Next. Within 2 days of release, Matthew visits community-based provider to continue MAT treatments, and Matthew meets his post-release care manager in the community to continue carrying out that treatment plan. So again, all of this is meant to be an illustration. We know timelines will differ, we know services will differ, but this is meant to kind of show you the art of the possible. Next. And then here's just a little bit of a chart that shows you, how those services are provided in this particular example, and by whom, whether it's embedded or InReach, and which billing system those claims would be submitted to. So it kind of walked through that on the slides before, but it shows you exactly here in just a different frame what that would look like, kind of rolled up in this table. Next. All right, so we know that we just went through a lot. We know that there's some questions in the chat that we're going to, or in the Q&A. We're gonna be busy working on those questions. There will also be a time for more interactive feedback, but want to take a quick break and let you think about what you just heard. Think about that timeline, think about what questions you have about how this would work in your correctional facility setting. How would you think about implementing behavioral health links? What are you now learning about all of the connections that need to be made at the local level for correctional facilities and county behavioral health agencies and our managed care plans? And what will you do? So feel free to share with us in the Q&A and in the chats. If you have Q&A, if you have questions, put them in the Q&A, but if you want to just chat in, like what you're thinking about doing in your county. You can share information there as well. We'll take a break now and come back at 11:04. All right, thanks, everybody. Hey, everybody, welcome back. Thank you. Welcome back. We're going to continue answering questions in the chat. There's a lot of them. So we're looking forward to that continued dialogue and conversation. But at this point, we would like to shift gears just a little bit and invite some of our colleagues to come on and talk about some best practices for providing MAT treatment, particularly in jails and correctional settings. So like some learnings from some prior work that we've done at DHCS to work with partners who are experts in this field and figure out how to make this work in correctional facility settings. So I am going to very warmly invite Bren Mana and Kelly Wright, who are part of the MAT in Jails and Drug Courts Learning Collaborative, and the team at HMA. So Bren and Kelly, thank you so much for joining us today. Health Management Associates has been a great partner to DHCS and to our county jails, and we're excited to learn from you today.
Thank you so much, Autumn. Kelly and I are thrilled to be here, and I know we're going to hear shortly from some of our county team member partners who were able to join today and share their own experience, which I know everyone will really very much enjoy and appreciate. If we could go ahead and go to the next slide. So I do want to preface this session by saying, as Autumn said, that DHCS has been sponsoring our work supporting California county jails and the larger justice system, including juvenile systems and correctional facilities, for almost 6 years now. And when we started this work in California, we were really at near functional zero in the California county jails for access to MAT. I think our baseline data point was 25 people who were able to access MAT at the beginning of this effort in a small number of counties that were enrolled initially in the Learning Collaborative. That data point and the involvement and engagement of the counties in the Learning Collaborative has really grown over time. We want you to know that we do currently have 25 counties participating in the Learning Collaborative. In the appendix or resources, you'll see a slide that includes a link to those 25 counties. If you are in a county, and I know we have quite a few folks from behavioral health agencies and others not at the correctional facilities. If for some reason, first of all, if you aren't sure if your jail is participating in the Learning Collaborative, you can check that link. And also, probably more relevant to most of you, if you would like to connect with one of the county jail teams that is doing this work as part of the Learning Collaborative and has really moved down the track with MAT implementation, we are happy to connect you with your counterparts in other counties. When we say Learning Collaborative, that's really been a primary aim all along, is not only to disseminate subject matter expertise and information, but to really build a community of county jail teams who can learn from and support each other. And we are very happy to facilitate that. So what we've heard today laid out very well, I think, both the expectations of DHCS for this transformation and also really the prevailing best practice standards, which are reflected in that transformation system. So I want to be really clear in saying that I'm going to be reiterating some of that, but this is really based, as we were asked to do, on lessons learned and the experience so far with the close to 40 counties who have participated in the Learning Collaborative over the course of this initiative. So you're going to hear a lot of the same language and words, but I really want you to know that we're speaking those words, that language, from the vantage point of lessons learned by all of these dedicated county team members who have been doing this work for a while now. So it's really going to reinforce for you what DHCS is laying out as the standards and goals for this initiative. I think at this point, probably most people really know the importance of providing MAT in correctional facilities, but we just want to revisit this. Maybe you have colleagues or counterparts in your counties who don't necessarily yet fully understand the imperative of MAT for people in the correctional system. And you play a role in advocating for that or helping to disseminate that information about why it's important for everyone who's involved in responding to and treating people in your county, that they really understand the imperative for making this evidence-based and life-saving treatment available in correctional facilities in California. So first of all, there's a very hot off the press statistic from NIH. You'll see that source in the references, that still most people in the country are not able to access MAT when they're incarcerated. California, of course, because of all the great work there, is the exception to that. And thankfully, we do have significant access to MAT in California at this point. But there are also still a lot of counties who have not implemented MAT yet in California. So again, if you're one of those counties, lean on us. We're going to be available for a few months to help you talk to other counties who have made this journey. We know that there's an exceptionally high risk for people who have OUD, who are incarcerated, who are not treated for that OUD while they're incarcerated, whether that's with continuation of treatment from the community or because they're not treated for their withdrawal or provided initiation to treatment. It's the highest cause of death for people living in incarceration facilities is overdose death due to untreated OUD. So we also know with MOUD being evidence-based, it can decrease that risk by 60 to 80%. Again, there aren't very many medical interventions that we have that have the efficacy and the impact that MOUD does. So we want to make that happen for everybody in California county jails. Next slide, please. So I just mentioned withdrawal. So, of course, the Bureau of Justice Administration came out last year with new withdrawal management standards for jails and correctional facilities. We've been supporting our participating county jails with adjusting their operational practices to align with those standards. It's important to note that this is not only a humane issue and a facility management issue, but also a huge risk issue in terms of potential death. So people who are not treated for opioid or alcohol withdrawal appropriately in a correctional facility can and do die from that. And of course, as I mentioned, there are other significant adverse outcomes for not managing OUD or AUD in a correctional facility appropriately. Next slide, please. Again, continuing with why this is so important, and this is to help empower you all to engage your colleagues, partners, and stakeholders in this if they haven't already really come to understand the imperative of providing this treatment. So drug intoxication deaths in correctional facilities have continued to grow exponentially nationally. Again, looking at California, this continues to happen in California county jails. And we want to do everything we can to make sure people access this treatment and don't die while they're incarcerated. And I think it's also important to note, this is a really important, again, humane and civil rights issue. And that in that there are a whole lot of people incarcerated in jails who have not been convicted of a crime, but of course are being held in those facilities awaiting adjudication processes. So again, they deserve to have, as every other community member does, access to the standard of care to treat their clinical, medical, and other conditions while they're incarcerated. Next slide, please. So again, from the risk management perspective, and I'm speaking, largely to those jails and correctional facilities who are not yet providing MAT in your facility. There's consistently found in favor of plaintiffs in cases where this treatment is not made available. It's a large and growing body of case law, finding both facilities, counties, and individuals liable in cases where the treatment is not available. And as I mentioned, part of the standard, the legal standard for that, besides the clinical and medical standard, is that the treatment that's provided in a correctional facility, including those who have OUD or AUD, is that they are entitled to treatment that is evidence-based and aligned with the community standard of care. Thankfully, across the nation and in California, many custody leaders are coming to recognize that OUD is a chronic disease like other chronic conditions that can be effectively treated, and recognizing, and you will hear this from our jail county team partners today, that when that treatment is provided, it not only saves and improves the lives of those people served, but really overall improves the correctional facility environment in terms of reducing custody challenges and other adverse outcomes. Next slide, please. So just to reiterate that point, I know almost a majority of you on today are from the county behavioral health agencies. It's really important that we, if you're not already, really think about the jail and the other correctional facilities as another link in the community's healthcare safety net. People providing healthcare and treatment in the jail already know this. They know it's their charge to provide healthcare in the jail and to do that at the prevailing community standard. Their key stakeholders and counterparts outside of the jail don't always know that. So that's part of our mission too, is to really get people away from this idea that, you know, someone sort of, a community member kind of drops into a black hole and that when they're in the jail or otherwise incarcerated, and then poof, they reappear in the community when they leave incarceration, and oh, now they're back on our continuum of healthcare in the community and we have to deal with them. So I know we have tremendous opportunity and potential here with the inReach and all the other aspects of this system transformation, but we really have to get our heads in the game in terms of thinking of that jail setting or that correctional facility as a key part of that safety net or community healthcare continuum. As you heard Autumn talk about in detail, as part of that, we have to really be person-centered in our approach and think about where somebody is appearing in the system and how we knit together that system around them. In working with jails and other CFs for the past 6 years in correctional facilities, we have seen jails really challenged by and struggle with how to knit the system together in that way when it comes to building the partnerships, creating the infrastructure behind that in terms of data sharing, timely communication. So the challenges are real, they're there, but we've also seen jails really dig in and develop solutions for how to make that happen. So again, we have some people who have blazed the trail and that we want to help you all really take advantage of and are happy to connect you with on these kinds of issues. Next slide. So one of the key challenges, you know, in our scenario today, we had a predicted release. I heard you acknowledge, Autumn, that you all understand that that's often not the case. That continues to be a huge challenge for jails in terms of planning for continuity of care in terms of assessments, authorizations, treatment planning. So I really can't overemphasize the challenge that that brings to correctional facilities. So everybody's going to have to really work hard together to be intentional about how you put processes and partnerships in place to address those precipitous releases. And again, another really big challenge is that sharing of patient-specific information, not just due to 42 CFR and other privacy concerns, but the fact that we're often dealing with multiple platforms and systems for collecting that data. Often even within the jail, there may be 3 or 4 different data management systems. So another really critical challenge that has to be addressed, along with For many jails, the issue of resources, not having 24/7 medical, not having 24/7 nursing, many of the jails actually don't have those resources. So to understand that and really think about how you can develop innovations and methods to overcome that. And again, we have examples of that. We have, the jails that have figured some of these challenges out. And we definitely want you all to be able to take advantage of that learning. Next slide, please. So another thing I really can't overemphasize is stigma. So we always start from the standpoint of engaging people and really understanding the brain-based chronic disease of addiction, and having the light bulbs go on about that. Because if people are coming from a place of misinformation, misunderstanding, or stigma, it's going to be really hard to make those operational changes that are needed. Finance, budget, staffing, those are all real challenges. But just like with any other healthcare need in the jail, when you put together an integrated team that has the right information and support, it can be figured out. So I've got really limited time today. I've got about 1 more minute, so I'm just going to try to move through this real quickly and wrap up so we can get to our panelists. But I'll point out that all of this information is in the slide deck. Will be available to you. You will see an email to our project email. Please let us know how we can help you with answering questions about anything that's in the slides, talking further about best practices, lessons learned, and as I said, very happy to connect you with our county team partners who are always very generous with their time and willing to talk with their counterparts in other counties. So with that, I will pass it back. Thank you all. It's a pleasure to be here with you today.
All right, so great. So thank you so much for the presentation. Super helpful information that you are sharing with us today. I think it gives our folks a lot to think about. We have questions, coming into the Q&A, so we'll take a look out for those as well. And thank you, Bren, for putting your email address in the slide that we can see. We're gonna do a live Q&A, but before we do that, we want to turn it over to our county panel. So we do also have folks from Imperial, Sacramento, and Santa Cruz counties. You can go to the next slide. Who are going to share their experience from the county perspective. So Tally Kennedy from Santa Cruz County, Cassandra Costa from Imperial County, and then Tiana and Mike from Sacramento County, Tiana Hammock and Mike Wanless are going to kind of share their own best practices for implementing MAT services. And then we'll open it up and you all could ask questions of any of our panelists today, including HMA or our county folks. So please stay with us, Bren, and I think we'll first turn it over to Tally from Santa Cruz County.
Hi, I'm Tally Kennedy. I'm the district planner here at Santa Cruz County Jail with NAFCARE. Just kind of a brief overview. Our MAP program started in 2020, kind of right in the middle of the pandemic, and things were very disorganized, to say the least. We started with continuation, not induction, and we maintained that for quite some time. I'm not sure if anybody on here remembers, but there used to be a cap of 30 patients for the actual license itself to prescribe. So we kind of stayed with that for quite some time after we did start the induction as well. We have moved through several iterations of the program itself through the last couple of years and just trying to kind of find what fits. I was working as a medical assistant previous to me taking this position, which I took roughly about 1.5 years ago. And we actually got a side counselor who is amazing. And we had that position open for a really long time, that being filled. And so that really kind of crippled us a little bit as far as our growth. in 2022, 2023, we had a steep increase in overdoses in the county. And so our chief, under sheriff, and lieutenant were kind of putting a lot of pressure on us to really increase our size of our MAP program. And that's when we started working with the HMA group, which was really super helpful for kind of both sides of it, our doctor and our custody partners. There's, a lot of stigma around opioid use disorder, and especially in the correctional setting. And they were extremely helpful on kind of explaining the medical side of, addiction to our officers and to our custody staff, that really helped them move into a place of support for us to be able to grow our program. So right now, we have roughly 70 to 75 people on our MAP program at any given time, and our ADP is generally like around 250 to 300. So it's, a pretty good portion of our folks who are on MAP program at some state. We started doing like detox meds as a way that we started doing our MAP program in the beginning, and then we would taper them off and then have the site counselor meet with them and then to continue them. We quickly realized that really wasn't the best way to do things. It was just creating a gap in the care that we were providing, and it just really wasn't useful for them or for our staff in any way. So what we do now is we initiate MAP medications on day 1 to 2, depending on their detox score, their COW score. And then they will meet with our site counselor at some point, usually within the first 5 days, and talk about continuation, how they're doing on the medication, et cetera, while they're still being checked on by nursing as well for their actual physical detox symptoms. We keep them on oral for as long as they want to, and as long as they want to be part of the program. We did start offering injectables through a grant from the HMA in September of last year, which was super helpful. We blew through the money very quickly. We had a lot of interest in injectables, and I think the grant was for originally $80,000, and I think we used it within like the first 4 months. So we really kind of grew very, very quickly during that time. Since then, our county has stepped up and found funding of their own to continue our injectable program, and we've moved mostly over to Brixadi at this point. We do have a few that are still on Sublocade, but we kind of moved over to Brixadi when it came out earlier this year. We started giving it in May of this year, and that's been fantastic. And like I said, the buy-in from our custody partners has been huge, and they kind of moved around money as far as their budget goes to make that something that is sustainable for us, which has been fabulous. We switched over from WellPath to NAFCare in July. And so some of our policies and procedures have kind of changed around detox procedures and stuff like that. But they have been really great in working with us about stuff that we already had set in place, and, kind of just how we do things already, and have been really great partners as far as keeping our MAP program going really steadily. Not sure if there was any other things that I was supposed to cover there.
Sorry, I forgot to come back off mute, but yeah, sounds great. I know that there will be a Q&A period, so if you can hang on, then we can go ahead and let folks ask you questions. But let's first turn it over to Imperial County and Cassandra.
Hi, good morning. I'm Cassandra Costa with the Imperial County Sheriff's Office. I'll start with saying that being a Sheriff's Office employee and part of the correctional staff, it appears that my other two counterparts on here speaking today are medical side. So I think my perspective is going to be a little bit different than their side. But I do want to give kudos to Tiana and their program in Sacramento. I was on a Zoom yesterday with them, and Imperial County is like 1/72nd the size of Sacramento population, but we could only hope to grow up to be like them one day. So I am looking forward to her presentation. So with Imperial County, we started with Matt in 2019 with our first program, very small. We have about 350 to 400 is our population on any given day. We are consistent in growing. So we started with just our MAT program, and with that, we were able to build our partnerships within the community. So our behavioral health partners are just like our staff here at the jail. We have developed incredible communication and consistent follow-up. Just last year, we were in a transition period between our WellPath medical provider and our NavCare is our new current medical provider. So since NavCare has taken over as our medical provider, we have made leaps and bounds in our ability to provide MAT services. We are currently in a 24 hours. MAT medications are administered within 24 hours of booking, regardless of the COWS score. So we went from anywhere between 20 and 30 at a time in our facility to 80 to 100 on any given day on MAT in our facility. Two of our, I guess, larger kudo areas are we were able to currently establish providing Narcan within all of our housing units. So we do have pouches that have been installed with instructions posted with each pouch in English and in Spanish, because we are a border county. So we do have primarily Spanish speaking incarcerated individuals. And also we have established in our via path tablet system videos that have to be videos and documents that have to be accepted prior to their use of the tablets that show the videos of administration and Narcan and its purpose. So we are happy that seems to be going well. Obviously, just like a little kid, anything you put new into a module, everybody wants to touch and know what it is and how to use it. So we are going through those learning hurdles on individuals that want to try and taste and see and touch. So we've only had one module where it's actually been used. The other ones were just removed, but we do have a procedure in place that is the officers are required as part of their safety walks to be checking the pouches that are mounted in there, and they have to sign off on that it's that the pouch is still full. Therefore, if it is being used, then it would initiate an investigation and follow up through camera visuals to find out who, where, and when it was used or taken. So that took some time and procedures, but we are grateful for that early access medication being available to our individuals right now. And then we have just recently signed our amendment to our medical contract with a full MAT program. And with that MAT program will be a MAT specific counselor, MAT specific nurses, and basically taking our jail and medical staff run MAT program and really honing its accessibility and its progress, being more focused and official instead of just something that we've been working towards. So we are really excited about that, and with that came our case manager. We have now myself, I am the department's reentry care coordinator and case manager for all of our incarcerated individuals. And so having that at a sheriff's office level is not really something that we hear a lot about. They bring in from other agencies or resource from their behavioral health, but having a sheriff's office on staff case manager where I can just walk into a housing unit and pull the individual that I need to meet with, and not adding time to correctional staff on the floor or interrupting their daily functions has really made an impact on their willingness to the correctional staff's willingness to participate, where we've worked tremendously with them on trying to create pathways that don't impede their day-to-day process. So that buy-in came, the more we worked with them, the more buy-in we received. So I think that is where Imperial's at on its updates and success with Matt.
Great, thank you so much. All right, we'll move to our next county and go to Tiana and Mike.
Hi, everyone. Good morning. Thank you, Cassandra, for that shout out. I really appreciate that. So again, Tiana Hammock, I'm the Health Services Administrator. And just to kind of give you a little background context on our jails in Sacramento County, there are 2 of them. And our average ADP between the both are about 3,200. And so we're a larger jail in comparison. We have on average 80 intakes a day and the same number of releases a day. So there's a lot of churn that's happening in Sacramento. In 2019 is when we first entered a learning collaborative with HMA. And at that time, it was strictly to continue MAT. We wanted to set processes in place to make sure that anyone coming in with a valid prescription continue their medication just like we would any other medication. That was a big lift. It was a really big lift. We had to change our intake process to identify people and set up a process for verification. We had to change our policies. We had to change mindset, right? The stigma that people should be allowed to continue their medication from the street. And so, so when we were doing continuation meds only, which was for a couple of years, we were averaging about 80 to 90 patients on MAT at any given time. And it was largely methadone, and we have a contracted provider, largely buprenorphine with a contracted provider for methadone. Just as the other counties were saying, in 2023, there was a large number of overdoses that were happening. California has a lot of fentanyl. And at that time, we knew that we needed to do something to address it. And so we got together, sheriff and medical, and we had a class counsel, which is, the lawsuit that we're under, also were pressuring us to do full induction. And because I'm a champion for it, my background's in substance use disorder, we had champions of the providers in the jail, Mike Wanless, who's our pharmacy director. We're all like, okay, let's do this. And we rolled out a 3-phase system for a full induction program. And because we're such a large jail, we knew we needed an induction unit where we can actually house people that were coming in a particular unit, where we can have a MAT provider stationed in that unit to do the inductions. And so there was not a lot of time for preparation because we needed to act urgently. But there was a lot of collaboration between us and the sheriff, and we created an entire unit for it. We already had a model with our withdrawal monitoring unit, so we kind of just made a similar model. We changed our intake process to identify people. We had to create a flag to communicate with custody to say this person needs to go into the MAT induction unit. And we had to have providers that were willing to staff the unit, which was a lot harder than you would imagine. And so we had to deal with all of that. And so eventually we just continued on the course. Even if there was pushback from staff, from sheriff, we knew that this was life-saving medication and that this is what we needed to combat the fentanyl crisis that were happening in the jail. And so that was last October where we actually created the unit. And so we're now almost a year in. And we have about 23% of our population that's on MAT right now. I pulled the numbers from this morning. 692 people on buprenorphine, 21 people on methadone, and 48 on Sublocade. And as you can imagine, that's a massive number. And so we relied heavily on HMA, connecting with other large counties that were doing it, Orange County, because there is a lot to go into it. We created an entire separate pill call line. So that way, people would come out 5 or 10 at a time, and then they separately from pill call would take their medications, because obviously diversion was a problem even when it was just continuation. Here's the good news though, for those that are worried about diversion, is that once you start meeting the need, the price point for Suboxone in the jail goes down, because now it's no longer a thing, right? And we actually just had a monitoring visit last week where a patient was interviewed and they're like, nobody's selling Suboxone anymore. Everybody that needs it gets it. And so it really has removed that from the equation. And so for those of you that are still combating the diversion issue, we were too. We created the separate pill call line. Another thing that was really key is we have a feedback loop with custody, that when they do cell searches or when they do shakedowns and they find that, you know, somebody's been hoarding Suboxone, then we meet with them and they are given the opportunity to get on Sublocade or be tapered off their medication, because obviously they're not taking it as prescribed. And that's why we have 48 people on Sublocade now. And so it's working well. We now have addiction medicine specialists that are manning the MAT induction unit. That is not necessary, but it is helpful because, you know, they're there because they want to be there. And that took a while though. We started out with just our normal in-house providers in order to man the induction unit. I'm gonna hand it over to Mike in a second, but I wanted to say, like, some of the lessons learned is that we really have to be collaborative. We have to dispel those myths that exist not only with custody staff, with medical staff as well. You know, we actually had staff go to the board of supervisors when we were going to roll this out and say, if we start inducting people on MAT, there's overdoses that are going to dramatically increase. And we know that that's exactly the opposite. And so it's just really dispelling those myths that come up, you know, when people think of MAT. Another thing is, you don't have to wait until you have a full, you know, set of substance use disorder counselors in order to treat someone with the medication, because the truth is the medication is going to save their life, right? I mean, obviously we have 3 substance use disorder counselors that do groups and one-on-ones and do the discharge planning, but that's not enough to meet the entire need. So we worked with our behavioral health, Sacramento County, shout out to them. I know they're on the call. And we worked really closely together on putting information on the inmate tablets, educational videos, resources for the community, because we don't know usually when someone's going to leave. They know that there are resources in the county for them because we've been able to partner with our county behavioral health. I know it's important also that pharmacy is heavily involved, so I'm going to turn it over to Mike.
Good morning. My name is Mike Wallace. I'm the pharmacy director for Sacramento County. One of the reasons I am here is because pharmacy is integral on it, and we are fortunate that we have our pharmacy in-house. We have 2 pharmacy at each jail, so we are fortunate in that. For those smaller counties that don't have the pharmacy in jail, it's definitely to get them involved very early in the implementation phase, because there's all the major wholesalers out there are under called controlled substance monitoring program, and because the buprenorphine is a controlled substance, the wholesalers can stop the distribution to you. So you have to actually let your wholesaler know that you're starting this program and that that the medication need is going to increase. There's a lot of changes that have to be done with within the pharmacy, depending on how your facility actually dispenses medications. Prior to MAT, all of our controlled substances were dispensed out of a Pyxis or what we use as Omnicell XT cabinet for the controllability of the medication. Obviously, because we moved so quickly from, and I don't know if Tiana said this, but I think October of last year, we were at like somewhere about 60 to 70 people on buprenorphine. And I think earlier this month, we were at 700 people on buprenorphine. So the amount of time it took those nurses to pull those medications was enormous. So now the pharmacy actually dispenses daily patient-labeled medication to the nurses, so they don't have to pull it, with maintaining the controlled substance and accountability for that controlled substance. Like Cassandra said, she has the pouches of the Narcan out there. We as well. We have what's called an opiate rescue kit. It's just basically plexiglass, acrylic clear box with some Narcans in it that's safety sealed. The pharmacy, for the most part, is in charge of putting, replenishing the Narcans in the units. Just like Cassandra said, yes. And we've been doing it for, I think, 4 or 5 months now, and we're still having people take it out, especially the ones in the holding area, the tank, the release tanks and stuff like that. They're just pulling them out, using them, squirting on the friend. I don't know what they're doing with it, but it's definitely not, it's not always used for overdose. It's just they want to see what it is and see if they can get a high from it. And probably the last thing is one of the things that we do. We are looking at Sacramento County moving forward with CalAIM is looking for a 24-hour pharmacy. We are actually moving towards that direction for 24-hour pharmacy. Right now, my pharmacy is open from 5 a.m. till 9 p.m. So it's not that much more of a stretch to get over the hump. And that's to obviously for the discharge meds. We do a large amount of discharge meds now, and we try to encapsulate all the SUD as well from the MAT, so we can actually get them their 30 days supply of meds on release in hand. On those methadone patients, it's a little bit more difficult, as you know. So we will dispense Narcan to them, so they have at least Narcan to go out. And then recently, we're in the process right now of having readily available Narcan on the way out. Eventually we'll get a vending machine, but we're way on that. So we're ordering a decently large amount of Narcan from the state. And also I just recently ordered which I just saw became available from the state, was the fentanyl testing kits, which allows the inmate or patient to actually test their drugs to see if it's contaminated with fentanyl. Obviously, if there is somebody that is, addicted to methamphetamines and not truly addicted to fentanyl, that really becomes important for those individuals that are leaving the facility, because they're probably going to go back to methamphetamines, and to know that their drug is somewhat clean and is not going to kill them as fast as fentanyl. The state does provide those tests as well. So we haven't quite put those in place yet, but we're getting there.
Real quick,
All right.
wanted to jump in on one last thing, is that we are going to do a training at the next NCCHC conference on our MAT program, because a lot of the conferences are still on the continuation aspect and not the induction. So we're really proud to be able to feature Sacramento at the next conference.
Thank you, Tiana and Mike. Thank you so much. I think Cassandra, having the perspective of the sheriff's office is super helpful. And the work that you're doing in your county. And then, just thank you to all of our panelists for joining. Tally, thanks for being here too, for joining the conversation today. This has been an extremely helpful panel, I think, to hear both from HMA's experience in working with county jails to implement MAP programs, but also, hearing directly from your colleagues that have implemented these programs has been, I think, an invaluable experience. We are running short on time. I know I promised you all that you'd have an opportunity for live Q&A, but what I'd like to do is invite all of our panelists back to our office hour session next week, if you can make it, so that we can make sure that folks can ask the questions that they have based on your today's presentation and discussion. So folks, if you didn't get your questions answered, which I know we won't have time for today, please write them down and bring them to our meeting next week, so we can discuss and continue the conversation during our office hour session next week. Thank you all for your generous time, for preparing and sharing with us, lessons learned and best practices today. Again, I think that this is an incredibly beneficial part of this Learning Collaborative series, and I'm glad that you are all able to participate. We do only have a little bit of time left in today's session. So want to close the panel for today. Lots of really good information. but thank you all for being here and for sharing. So we'll go to our wrap up. We'll skip that part. Thank you. Sorry about that, folks. I think we just had too much good information for you today. But that's why we have the office hours, so we can continue the conversation next week. With that in mind, let's go to the next slide. You'll see next week, we invite all of our correctional facility partners, so whether you're with the sheriff, probation, the county entity responsible for correctional healthcare services, or others that are implementing this on behalf of the county, invite you back for the county specific office hours next week. Our county behavioral health agencies are also invited to that session. So let's continue this conversation about MAT and jails and best practices and answer questions. We'll spend a little bit of time in the office hours next week discussing that specifically. And then we'll also leave time for our county behavioral health agencies and correctional facilities to talk about more the BH links, and we'll answer questions that you all have about what you heard today on those topics as well. If you didn't get your questions answered in the chat, and you're not a correctional facility or county behavioral health agency, please join us on the 10th of October for our general office hour session that will happen in 2 weeks from today. We're also going to be sending out the recording and transcript as we've shared, and starting to put together the FAQs from each of these sessions, so that any questions that were left unanswered in the Q&A, and I know that there's still some pending that we didn't get to yet, that those can be addressed so everybody has the information that you need to move forward. So hopefully these sessions have been valuable. We think that they've been great. And looking forward to continuing them. The next session, bigger session, is going to be focused on non-behavioral health services specifically. So what does the clinical consultation set of services look like for physical health conditions and that warm handoff piece, but particularly, what are some of the treatment scenarios for physical health clinical consultation on October 17th, and then we'll have a whole session dedicated to the handoff to the enhanced care management providers for the JI population of focus. Kind of go into that on November 14th, and then a pharmacy policy conversation in early December. Just so you know, in the background too, we have 3 counties that are about to go live next week. We'll also build in some time for learning for those, and just want to take a moment to congratulate those 3 counties, Santa Clara, Yuba, and Inyo. We know that there are still some things in motion, so whether it's the 1st or the 2nd or the 5th, that we're getting started starting next week. So we'll make sure to hear from them, but it's a huge milestone for our colleagues from Santa Clara, Yuba, and Inyo. And so this timeline, for those of you who are not from those 3 counties, we're making sure that we're reaching out directly to those counties that are looking to go live next week. The 5 counties that applied for readiness for January will also do that to make sure that you all have the information that you need in order to implement. And then we know that there's been a ton of questions today about the JI screening portal, screening portal. And we did conduct those trainings on September 10th and 12th. The recordings and information from those trainings are available on our Medi-Cal learning portal, and Ashley put the links for the trainings in the chat, so that you can kind of access those. Ashley Deli also put into the chat information about the Medi-Cal learning portal and registering for that for the trainings, and the Medi-Cal subscription service so that you can get the communications for your service type. So make sure you sign up for all of that. We did, as Greg said in the beginning, have to reschedule the billing trainings, but those will be rescheduled for mid-October. So all of you with questions about billing, whether it's behavioral health billing or fee-for-service billing otherwise, those trainings will be coming up in mid-October, and we invite you, not only invite you, but encourage you strongly to participate in those sessions as well. So you see kind of just a timeline of the next steps. We just walked through all of that. You can submit your office hours questions to us in advance so we can be prepped, and we'll share those with our 3 county colleagues from Santa Cruz, Imperial, and Sacramento in advance so that they can also be prepared for next week's discussion, and our HMA partners too. So thank you all so much for being here today. Hope you join us next week. We know that there's still a lot of questions. We're doing our best to get to all of them, and we will answer more questions next week. So thank you all for joining, and hope that you have a wonderful rest of your day and weekend. Thank you all.